This is the current reality of HoLEP. So, what should we do to overcome these challenges? I've thought of a few points, and I'll share them briefly within the time we have. The first issue with HoLEP is its steep learning curve. From a systematic review, it is evident that you need to perform at least 50 cases, which is comparable to robotic prostatectomy. This example is just for fun, but the audio isn't great. Here, you see a scene from the movie Welcome to Dongmakgal, where an American soldier is injured and tries to communicate. But because they can't understand each other, they resort to a textbook-like exchange. How are you? I'm fine. Thank you, and you? I'm fine. It would be great if things worked this smoothly, but as the prostate grows larger, HoLEP also encounters more and more challenges. To overcome this learning curve, it is recommended to start with an appropriately sized prostate, ideally less than 80 grams. Additionally, a mentorship program can significantly shorten this learning curve. Then there's simulation training. Professor Oh Sung-jun has developed a simulator, and I participated in some aspects of this project. The results showed that various performance metrics improved significantly when using the simulator compared to just listening to explanations. So, it's clear that simulators are helpful in overcoming the learning curve. Now, what do beginners find most difficult? Handling the apical portion and managing lateral planes are identified as the two most challenging aspects. For the apex, as we process it, we follow the guideline to not go beyond the verumontanum. The external sphincter looks like this crescent-shaped structure, and it's important to avoid cutting posteriorly behind it, particularly at the 12 o'clock direction, where the structure is more proximal. Most experts suggest resecting closer to the proximal area and avoiding extending distally. This approach reduces the risk of incontinence and makes the process easier. Another technique is early apical release, where we first resect this area to simplify subsequent steps. Then there's the SNUH modification. Instead of resecting in a circular shape, this technique involves leaving more mucosa using an inverted V method to preserve as much mucosa as possible. These techniques make managing the apex easier. For lateral planes, the verumontanum serves as the landmark. You can see that the peripheral zone is thickest in this area. Carefully following the plane ensures a safer and more effective procedure. The second issue with HoLEP is retrograde ejaculation. Most patients experience this as a side effect. Professor Kim Young and Professor Paik Jae-sung explored whether preserving the verumontanum hood could help, but their study found no significant effect. In 2021, another study investigated whether preserving structures during HoLEP to prevent anejaculation was a myth or a reality. The study focused on preserving the ejaculatory muscle in front of the verumontanum. Why is this important? The muscles responsible for ejaculation, including the anterior and posterior ejaculatory muscles, are located near the verumontanum. Historically, the bladder neck was thought to play the most important role in ejaculation preservation. But now, these muscles around the verumontanum are considered more critical. During ejaculation, the ejaculatory muscles in front of the verumontanum acts as a barrier, while the contraction of these muscles drives emission and expulsion. By preserving just 1 centimeter above the verumontanum, the success rate for preserving ejaculation is about 85%. With TURP, this can be done cleanly, but HoLEP doesn't achieve this as neatly. So, while it's promising, the technique remains challenging. Another common issue with HoLEP is overresection. Surgeons may be tempted to cut more than necessary, but this increases the risk of damaging the ejaculatory ducts. By sticking to the planned planes and avoiding excessive resection, these risks can be minimized.